Good day, Ma'am Fajardo. We are Group 1 from Section EF and we will be presenting our case. Our case is a 59-year-old man with a history of cirrhosis secondary to hepatitis C and alcohol abuse who was referred to a hepatology clinic for a consultation on 2 new liver masses. The patient was diagnosed 10 years ago with hepatitis C during a life insurance physical examination. At that time, he was treated for 6 months with ribavirin and interferon alpha 2B combination therapy but did not respond. 3 years ago, a liver biopsy was performed which showed stage 3 fibrosis with grade 2 to 3 inflammation. Since then, he received ultrasounds every 6 months to screen for hepatic lesions. His last ultrasound showed 2 small lesions, and MRI confirmed 2 hepatic masses of approximately 2 centimeters each. The patient had a history of alcohol abuse, consuming 12 to 18 beers per week. At the time of referral, he drank about 10 beers per week despite being counseled not to drink alcohol due to his hepatitis C. In addition, he had a 2 year history in the 1970s of intravenous drug use but is currently denied IVDU. He had multiple tattoos and body piercings, all of which were placed in the 1970s. Liver function tests performed at his clinic visit showed elevated results for aspartate aminotransferase, alanine transaminase, gamma glutamyl transpeptidase, and bilirubin. His hepatitis C virus viral load was 186,319 IU per ml, and his HCV genotype was determined to be 1B. He had a liver biopsy the following day, from which histopathology confirmed his diagnosis. First, let's tackle the viral agent and the disease. The viral agent responsible for the disease is hepatitis C virus with the genotype 1B. There are 6 different genotypes for HCV, which are genotypes 1 through 6, and there are also subtypes for each genotype. Among the different genotypes, genotype 1 is the most common. An infection of subtype 1B, which is the viral agent in the case study, is associated with a more severe liver disease and a more aggressive course than the infection with other HCV genotypes. The patient is suffering from chronic hepatitis C based on his history of cirrhosis and alcohol abuse. His liver biopsy result also showed stage 3 fibrosis with grade 2 to 3 inflammation.
Now let's move on to the morphological uniqueness of the hepatitis C virus, wherein we'll discuss the intact virion, the envelope, the capsid, the nucleocapsid, the RNA genome, and as well as the lipoviral particles associated with the virus. The hepatitis C virus, or HCV, is an enveloped positive strand RNA virus classified in the Flaviviridae family. The HCV particles are spherical and heterogeneous in size, that typically ranges from 40 to 80 nanometers in diameter. Currently, there are 7 genotypes and 84 subtypes of the virus that are recognized. The intact virion is often associated with lipoproteins. The HCV envelope consists of the E1 and E2 glycoproteins non-covalently associated as a heterodimer. This E1 or E2 glycoprotein heterodimer is embedded in the host-derived lipid membrane and together forms the HCV envelope. The envelope proteins play a role in host receptor binding, endosome lipid membrane fusion, and assembly. The E1 protein is approximately 192 amino acids long, and the E2 protein is approximately 363 amino acids long, while the host-derived lipid membrane component of the envelope is composed primarily of cholesterol, cholesterol esters, phosphatidylcholine, and sphingomyelin. The HCV capsid, or also known as the HCV core, is the protein shell that encapsulates and protects the HCV RNA. It is made up entirely by the HCV core protein. The proteins on the outer surface of the core interact with the viral membrane, while proteins on the inner surface binds to several HCV RNA segments. Following cleavage from the polypeptide, the core proteins assemble at the cytoplasmic phase of the endoplasmic reticulum to form the capsid. This assembly process is triggered by the interactions with the HCV RNA and envelope E1 protein. During assembly, the core proteins use the HCV RNA as a scaffold upon which core proteins bind to and surround the HCV RNA. Meanwhile, the HCV nucleocapsid consists of the HCV capsid, which I've just discussed, plus the HCV RNA, which will be further discussed in the next slide. The HCV nucleocapsid is spherical and heterogeneous in size, with an approximate diameter of 30 nanometers. For the RNA genome, the HCV genome consists of a single-stranded positive sense RNA that is approximately 9,600 nucleotide bases in length. The HCV genome contains a single, long, open reading frame flanked by 5' and 3' untranslated regions. It is used for both translation and transcription process. The 5' region, which is upstream from the open reading frame, is approximately 340 nucleotides long and contains 4 highly structured domains. Domain 1, which consists of a short stem loop, and domains 2 to 4 form the internal ribosomal entry site. The 3' region is approximately 225 nucleotides long, and it consists of 3 components: the variable, a long poly tract, and 3' X region, which serves as a key factor in switching between translation and RNA transcription of the HCV RNA. Now, in the bloodstream, HCV can circulate as a hybrid lipoviral particle that consists of lipoproteins tightly associated with the HCV particle. The specific components of the lipoviral particle include triglycerides, HCV RNA, capsid protein, E1 and E2 envelope glycoprotein, apolap- apolipoprotein B and apolipoprotein E, and the formation of the lipoviral particle facilitates HCV entry into hepatocytes rather, and it protects HCV from antibody neutralization. Let's tackle the epidemiological distribution of the disease. Globally, incidence of HCV is higher in parts of Asia, Africa, and South America. Over 177.5 million people are infected, that represent 2.5% of the global population. Among the genotypes of the said virus, genotype 1 is the most prevalent with an estimate of 49.1%. However, when combined, genotypes 1 and 3 are common worldwide, comprising 67%. In the country, HCV was detected in 14 of 18 antibody-positive sera from blood donors, owing 78%, while an estimate of 83% of HCV detection in 19 of 23 antibody-positive sera from Filipino inmates. Finally, 18 of 800 sera, that constitutes 2.3%, were detected of antibodies against HCV.
Let us now discuss the pathophysiology of the disease, which includes the distinct diagnostic, the clinical manifestation, and the mode of transmission. HCV primarily attacks the liver and will lead to inflammation. The clinical manifestation of the disease includes jaundice, fatigue, nausea, fever, and muscle aches. The initial symptoms experienced by a person infected with HCV are often extrahepatic, most commonly involving the joints, muscle, and the skin. Example includes arthralgias, paresthesias, myalgias, pruritus, Zika syndrome, and sensory neuropathy. Moreover, the signs in patients with decompensated liver disease includes hand signs, head signs, Clitor hepaticus, ankle edema, scant body hair, and skin signs such as spider nevi, petechiae, and excoriations due to pruritus. Other common extrahepatic manifestations include cryoglobulinemia, membranoproliferative glomerulonephritis, idiopathic thrombocytopenic purpura, lichen planus, and keratoconjunctivitis Zika. Finally, the mode of transmission of the HCV is through direct contact with blood from an infected person and also drug injection equipment. For the laboratory tests that are appropriate for the identification or confirmation of the agent of infection includes serologic tests, which can identify human antibodies produced in response to hepatitis C virus, are used to diagnose hepatitis C infection. A positive HCV antibody test can suggest ongoing infection, a formerly active HCV infection that has been cured, or a false positive result. The enzyme immunoassay, or EIA, is used to identify HCV-specific antibodies, which is followed by a confirmation test. Antibodies that bind to recombinant antigens generated from the four HCV sections, such as the core, non-structural 3, non-structural 4, and non-structural 5, are detected using EIA. Based on an absorbance signal compared to a cutoff value, the EIA test is classified as a positive or a negative. To assess the current state of infection, the CDC advises that EIA positive specimens be tested for HCV RNA. RNA testing can also be helpful in the early stages of infection before the patient develops an antibody response. Hepatitis C should be checked in all adults, pregnant women, and those with risk factors. The majority of the person who get the hepatitis C virus have a chronic infection that lasts their whole lives. Anyone who has been informed that they obtained blood from a donor who tested positive for HCV should be tested. HCV serologic testing is recommended for anyone who has been on long-term hemodialysis or has persistently abnormal aspartate aminotransferase levels. Individuals who have been exposed to HCV by a needle stick, sharps, or mucosal exposure should also be tested. Women should be screened for HCV RNA until they reach at the age of 12 months.
Treatment and prevention. Combination therapy with pegylated IFN or interferon alpha 2A or 2B along with ribavirin has been the standard treatment for HCV, and the FDA have approved it as a direct-acting antiviral since 2011 and has been continuing to use it as a treatment for genotype 1 HCV. The cytokine interferon alpha is produced in response to the viral infection, and when a synthetic version is given, it will stimulate a non-specific response by boosting the immune system. The disadvantage of the interferon alpha, however, is that it has so many adverse effects that many people are unable to complete the entire treatment period. The PEG-IFN has a polyethylene glycol linked to an interferon alpha, which will extend the drug's half-life and allow for a higher viral activity and response rates, while the ribavirin will greatly improve the sustained virologic response or SPR rates when combined with PEG-IFN. The ribavirin inhibits viral RNA production by a nucleoside inhibitor, although the specific mechanism is still undetermined. Due to the high rate at which HCV resistance develop, ribavirin cannot be given as a monotherapy. Due to that, these drugs must be used in combination, and both these drugs have dramatically improved SPR rates in patient and treatment non-responders in clinical studies. Avoiding direct contact with other people's blood is the best way to avoid HCV infection. As a summary of our case study, the viral agent of the disease is called hepatitis C virus with a genotype 1b. And in terms of the epidemiology of the disease, HCV has a prevalence rate of 2.5% globally, and in the Philippines, 78% of blood donors were detected to be positive, and 83% of inmates and persons are also detected to be positive. Now, the virus mode of transmission includes direct contact with blood, sharing of contaminated needles, and unprotected sexual contact. Moving on to its pathophysiology, the virus attacks the liver, which will cause inflammation, and thus the clinical manifestation of this virus includes jaundice, fatigue, nausea, fever, and muscle aches. Serologic tests are used in the identification and confirmation of hepatitis C virus. And in terms of its morphological uniqueness, the hepatitis C virus is single-stranded positive sense RNA virus with an intact virion. It is enveloped and has a lipid membrane and a capsid with an icosahedral symmetry. It also has a lipoviral particle. And the treatment of HCV is a combination therapy of regulated IFN or interferon alpha 2A or 2B along with ribavirin. That's all. Thank you.